Welcome to The Digital Patient, where we discuss the latest advancements in digital patient engagement and share stories from the front lines. I'm your host, Alan Sardana, and with me, as always, is Seamless MD CEO, Dr. Joshua Liu. Today, we're joined by our very special guest, Dr. Ashis Barad. Dr. Barad is the Chief Digital and Information Officer at Allegheny Health Network, where he leads the deployment of technology to enhance the reach, access, and effectiveness of AHN's clinical care delivery, with a focus on both the patient and clinician experience relative to electronic health records, artificial intelligence-powered data analytics, wearable devices, and other virtual tools and platforms. Prior to joining AHN in the spring of 2022, Dr. Barad worked as the clinical lead for Baylor Scott & White's Digital Health Office and as a pediatric gastroenterologist. Dr. Barad, Ashis, welcome to the show.
Yeah, thanks, Alan. And yeah, please do call me Ashish. Really happy to be here. Been looking forward to it.
Amazing. Well, we're so glad that you could take the time to spend with us. You've led such an inspiring career spanning the clinical worlds, informatics, digital health, and health equities. And from what I can tell, you've been optimistic about the role that the right technology can play to improve healthcare, perhaps even longer than your professional career would show. I'd love to start at the beginning. I believe I've heard a story that your interest in medicine started after typhoid fever that you got when you were 8 years old in rural India. Is that correct?
Yeah, Alan, thanks. The story is true. Yeah, I was 8. I grew up in the US, by the way. I was born in Chicago, and we grew up in the States. I grew up in Houston. But we went back, as many immigrant families do, to go see family. So I was 8 years old, went back to India, and yeah, got typhoid fever, not salmonella typhi, as Josh well knows. And I think I lost like 25 pounds, which was like all of me at 8. I was a very skinny little kid, so I was on death's door for sure. And what was crazy, a couple of things that were crazy about it, a couple of stories around it, which was I was misdiagnosed, right? And because I was basically in a village in India where, some of my family they grew up in a village state. So misdiagnosed with malaria, wrong treatment, and wasn't getting any better. And then the second part, which really stuck, was my mom and my sister had come with me. We grew up pretty low income, and so they didn't allow my mom to change flights without a very hefty cost that she couldn't afford. And so they had to leave. And so right there in the middle of my typhoid fever that was misdiagnosed, my family took off. I was an 8-year-old, and I was left with my cousins that I'd never met before, and in a village in India. And it was a really scary experience. I recall it really well. But what saved my life was, luckily I had a cousin back in the States who was marrying a guy who happened to be a doctor in India, and so Manish, who is a family practice doc out in Iowa now, came in to take care of me, properly diagnosed me, got me on the right antibiotics and treatment, and saved my life. And then a month later, I went home, came back to Texas, came back to the States. So, and so it really sparked the interest of not just, a doctor taking care of me and really saving my life, but also the fact of, I don't think I would have made it without Manish. I really think that if I had not had proper access to healthcare from many different levels, it's accessing the right physician, accessing the right treatment, the right care, I don't think I'd be here. So I'm trying to pay it back.
That's amazing. And so you went into pediatric gastroenterology. At what point did digital enter your mind share? Was it all the way back then you knew, rural access and digital could maybe improve workflows, or how did you get into digital health?
No, I appreciate the question. Not as early as I wanted to. If I look back and I could change one thing, although I wouldn't change anything because I'm where I'm at and I'm happy with it. But I really just went one foot in front of the other to become a doctor. Nowadays, right, you can be like a doctor and a digital doc, and you can have some pathways. But back then, right, I'm older than you might think I am. I grew up with paper charts, by the way. So, it was just really a matter of you go be a doctor. So I did medical school and then pediatric residency in Texas. I went to Chicago for my pediatric GI training. So what happened in Chicago at Northwestern was probably what got me into this world of just technology, right? So up until that point, all paper charts, going in, hey, my attending saying, hey, she's go grab 423, right? And you go grab this big old binder, 423, and you bring it to the table and everybody looks at that and talks about things. So Northwestern said, hey, we're doing this thing that not a lot of people have done, maybe Geisinger at the time, but we're going all in with something called an EMR, and we're using this company that nobody knows called Epic. So they're like, we don't know how to go live. No, they don't know how to do go lives. So we're just gonna have fellows do it. Y'all seem like you're young and smart. Why don't you guys go do this go live? And so yeah, I got tasked to do the go live of Epic at Northwestern way back when. And that probably got me in the world of just technology. I am in no way, will never claim to be an informaticist. And that's not an offense, that meant to be offensive to informaticists. That is not my path at all. That wasn't anything that I wanted to really, it didn't spark my passion. I want to improve workflows. Gosh, I absolutely want to improve workflows. And as a practicing doc, I want that to be better. But at that moment, it wasn't, wow, this is what I want to do. I want to live inside the world of EMR and Epic and make workflows better. Like it didn't spark anything at that moment, but I got really good at just technology, if you will, inside healthcare. That sparked my interest of, all right, this is a new thing, right? We're going to start using technology in healthcare. So then I left Northwestern as a fellow, and I took a first job at Sutter Health in California as an attending as a pediatric gastroenterologist, full-time pediatric GI. And no kidding, that like, as soon as I get there, they're like, hey, we see that you're doing an Epic Go Live. We're doing that. Sutter's going live with Epic. And so, all right, I'll help you do that go live. So I did another go live. 20 months in, we were having our first kid. We missed home. It was fine. Time to go back to Texas. Got a job at Baylor Scott and White, as you mentioned. This is in 2011. And yeah, like no kidding, man. Within a year, they're like, we're doing this thing called Epic Go Live. So I did 3 Epic Go Lives like really early in my career. So it got me at least in the world of technology and informatics, if you will. And I helped Baylor Scott and White do that as well. But went back to practice, right? Like, I mean, just did that off the side of my desk. And then I became section chief of pediatric GI a couple of years after I started there. So my path was, being a physician first, being leader of physicians. I love that. We had a children's hospital and everything else. So what really, I guess, got me into the role of digital health, to answer your question specifically, is and again, not anything that anybody's not doing now with video visits, right? Not sexy, not innovative at all. But in 2013, to be fair, if you go back a decade, it was something that not a lot of people were doing. It was onesies and twosies of Skype, maybe with a call with the patient. If you remember Skype software, maybe I'm dating myself, but but what happened was, you got to think about Texas, right? Large state, a lot of rural America, second largest state in the country, right? Not very liberal with their money to Medicaid populations, and right? So Medicaid expansion hasn't happened still in Texas, right? So a lot of people that are a lot of equity issues, and so as a pediatric gastroenterologist, you can imagine there's not many of me. So people have a hard time for accessing care to specialty care, and especially in pediatrics. And when they do, I mean, I had people, no question, driving 8 hours to come see me for 15-minute visits. I mean, it's just silly, stupid, and really it was a check-in, right? Because the rules stated to give you a refill on anything, you had to physically see me. And it just, for me I think it was that moment for me to say, this doesn't make any sense. And so I did the first video visit for the system of all Baylor Scott and White. I built it inside Epic with Adobe Connect. I think that was the first time that got done. And so it was, it just, but I went right back to practice, Alan. Like it wasn't doing, I think it all comes back to like when we talk about what we're doing now, I didn't do it because it was shiny, it was cool, it was whatever, right? It solved a problem for my patient. My patient was driving 8 hours to come see me for a 15-minute visit. Why can't I meet them where they are? It gets overused now, but man, that was exactly what it was. It was like, how can I come to you? How can I be there with you? And honestly, right, the patients loved it. And no reimbursement at the time, living in a fee-for-service world in RVUs, so I didn't care. It was the right thing to do. And so that got me in the world of virtual. And then, I'll really give credit to Baylor Scott and White and their leadership at the time. In about 2015, the CEO at the time decided, we need a chief digital officer. We need somebody leading digital health. And this is before most places, right, had anything to do with digital health at 15. And so that's Nick Reddy, great friend of mine. He's still the chief digital officer at Baylor Scott and White. And so Nick and I got to know each other really well with the Epic Go Live and remained friends. And so, I created the first MyChart app. I think it was the first MyChart app that wasn't MyChart. It was a wrapper around MyChart to get to consumer grade, right? And that was at Baylor Scott and White. So I started becoming, in a sense, like an internal consultant, if you will, to them. I didn't want to leave practice at that time in any capacity. I enjoyed building my team of doctors and providing care. And then, really COVID is really what changed all of it. And when COVID happened, there was kind of a realization of, man, digital health is blowing up, right? Even pre-COVID. And that obviously we saw what 2020 did with digital health. And there's a lot of shiny objects out there, but nothing's scaling. Nothing's actually getting adopted. Engagement's really low, but we're spending a lot of money meeting with all these companies and bringing them in, but we're just really not seeing it go anywhere. So they had the insight to say, we need a clinical leader here to really vet all this. And so again, credit to Baylor Scott and White, credit to Nick, credit my CMO at the time, Alex. He's still the CMO, Alex Rolica. He's Chief Innovation Officer now, actually. And just making that recognition and tapped me to do that. And so that got me in the world of digital health. And, I called it a second fellowship. Absolutely. Because I learned acronyms that I'd never heard before, including CRM, SEO, even a KPI. What the heck is a KPI as a doctor? You don't know KPIs, so basic stuff. Right. So I took on a beginner's mindset and I was like, man, I just want to consume. I love this. I think that, I credit Shantanu Nundy talks about democratizing healthcare with technology, and that completely resonates with me. And that's what I believe in. And I was like, if we do it right, we can do that. And I want to be a part of that, right? And I want to be able to not just lead it, but also be able to kind of guide non-clinical people, non-healthcare people to make sure we're solving the right problems.
Ashis, I want to unpack something that you got into. So you mentioned how it was so important that you got into more of a clinical leadership role with digital health at Baylor Scott and White. And one of the things that you've mentioned, I think today, but also to me in the past, is that a lot of these digital health implementations fail because clinicians just weren't properly involved in the process, which sounds like an obvious thing, I think, if you talk to clinicians, but we see it happen all the time. It still happens today with health systems. What do you think the right level of clinician engagement is in rolling these digital health solutions out, and what are the pitfalls that systems can maybe avoid?
Yeah, it's a really good question, Josh. And you're absolutely right. That's exactly what we see, or you see that all the time with your company, right? And trying to get out there. And I think you do such a great job of making sure that that's at the forefront with the implementations, is to make sure that you have buy-in from the clinicians for the healthcare systems that you work with. Sure. So to your point, it's a tough arena, right? Because on one side of it, I have empathy for these innovative healthcare, companies trying to come into healthcare. We're tough. Doctors are hard, right? Like there's a big segment of us that don't want to change a thing, and we're comfortable. We really like where we are, meaning maybe we not even like it, but we don't want to change it, right? Like, nobody likes it. Don't get me wrong. Like nobody's like, oh yeah, this is great. This is really working for everybody. If anybody thinks that, sorry, like don't peg doctors like that, okay? Like doctors aren't like that. I go to the front lines, they're tired. It's, there's a storm coming, of physicians leaving. And so nobody likes it. But, we haven't proven to them that we're actually helping them with their work, right? EMR was the biggest kind of like pulling the rug out of their, under them in the world, right? I'm not like anti-EMR, but because I think it had its benefits. But, as it got rolled in, even though I was part of those go lives, I know this might be controversial, but come on, most physicians saw it as a billing and coding kind of platform. We didn't see it as this is going to really improve care. Yeah, that might have been a byproduct, but nobody really saw it as such. I was going back to cell phones, right? The biggest block of professionals that adopted cell phones beyond 90%, physicians. We're not against technology, but guess what it solved? You were stopped. I remember these days. You stopped and got a page, and you literally had to find a phone booth to answer the page from the hospital. Right? And you're at the baseball game with your kid, and you're like, oh my God, I got to go find a phone. Cell phones solved a real problem, and then physicians were like all over cell phones. Right? They're the first professional block to take on cell phones. We're not against technology. We're against the technology that doesn't make our lives better. Right. And then when EMRs came in, I was like, this is going to make your lives all better. This is going to solve the data interoperability. We're still talking about that, aren't we? So like, right, this was like way back when. And so it was kind of like, man, they just see it. Many of them see it as a burden. And so they're a little, I get it. They're a little cautious of these promises that oh, no, this time we mean it. This technology is really going to make your lives better. And we don't always prove it out. To your point is that, as we take on new tools, we're like, hey, it's just 5 more things you got to look at in this patient, right? It's going to be great insights. It's going to be wonderful insights. It's going to really improve the care of your patients. It's 5 more alerts, but these insights are the real ones. They're going to be great. Did you remove 5 things from my plate to add these 5 things in, right? So no, just do, it's just 5 more clicks, guy. Come on, it's not a big deal. So anyway, the answer is 1, I just want everybody to have empathy for where physicians are on their journey of technology adoption. It's not like they don't want it, but we don't want it. Everybody wants it. Everybody wants it, but it wants to really solve a problem, not just for themselves, for their patients too, but it needs to solve under the lens of them as well. Can't add just to solve for a patient. Okay, that's 1. Secondly, it is so important that health systems, to your point of what can health systems do, they need to find that physician leader that is still optimistic about what technology can do, but is still a frontline doc enough to where there's trust that, and that person can really speak to other physicians and be able to get adopted. And that's my job. A lot of parts of my job is going out there and saying, I get it, I empathize, and really be able to speak the language. But at the same time saying, but look at the other side of that. That's change management, right? Look at the other side of this, and that's what we gain. And then I'm going to work on taking a couple things away from you that are meaningful to you. So I do think physicians need to the table. And if you look around the country at chief digital officers, and you interview many of them, sure. And I get it. I understand that they came from retail or they came from technology. They came from other places. And I'm not faulting these people. These are great people with great ideas that are way smarter than I am. But they're challenged, right? They're challenged because they don't have, they can't get into the physician offices and speak that language. So if that's the case, I'm not saying all chief digital officers should be doctors in any way, but if that's the case, then they need to have a dyad, a physician, clinician. If it's a nurse, it's a nurse. I don't need to be a doctor, but a clinician dyad, in my strong opinion, to be able to help those clinicians along.
You brought so many great points. And I think it reminds me that in almost any other, business, like B2B industry, the customer has to be desperate for the solution. Like they have to have a real serious problem that you solve. Otherwise it's a nice to have. Otherwise it's a vitamin, not a painkiller, and then it won't get adopted. And I think what we remind our team here is that in healthcare, it's even more complicated because if people you're trying to talk to are clinicians who are, overburdened right now, they're running around a hospital or a clinic, they're in the OR, they are not sitting at their desk all day long where they can just get on a Zoom and learn about an innovative new solution. Right. So you have to solve a real problem, and somehow you have to have empathy for the fact that, yeah, you know what, their inbox is full, they don't have time all day long to take sales meetings. That's just the reality of healthcare, and we have to empathize with that situation. So I can't even imagine, in your shoes, in the hospital, you still have to somehow find these clinicians who may be running around and taking care of sick patients or in the OR, and it's not easy for you too. So that empathy is so important. You're right.
Yeah, I tell my team all the time, there's a concept of empathy in action.
Yeah.
Right. And we talk about that a lot. Empathy is important, but if empathy without action doesn't mean a whole lot. Yeah. You know what I mean? And so I think it's really important that it's empathy with, in action. And that means 2 things, which is you're seen. You need to be out there. I tell all my teams have to be out there in the hospitals and the clinics, be seen, be visible, and not just to be visible for visible sake, but then to gain further empathy, that virtual cycle of empathy, to be able to say, okay, because what we're in healthcare, another problem in healthcare is we're just reactive, right? The industry is just always reactive. In every way, it's reactive. And it's the same stuff. So right now it's reactive from a innovation or technology or even just standard IT. It's just, you put a ticket in, you tell me what you want. Well, same old school IT, right? Where it's just you put it in, what do you think, a doc or a clinician or nurse or operator? And then we prioritize and we go to, that's not how we need to be able to function. And because I also do, as the CIO role of it, I'm in charge of IT and Epic too. It's the same concept there is really we need to kind of get into a proactive approach of, if you do empathy in action, you're out there, you're talking to them, and you see them, and we're going to get into a proactive approach where you're going to know, proactively what the needs are of the business for customer success. I mean, I tell my clinical informatics team that's their job. Your job is customer success.
That's the
And
first time we've heard that, by the way.
Mhm.
That's really, really interesting.
Got
Yeah,
it. Anyway, yeah, that's awesome.
amazing.
Ashish, I was wondering, this empathetic action and actually understanding what the problems are and being proactive about a solution. Early on in your career, while you were leading groups of physicians at Baylor Scott and White, you were actually awarded for your exceptional productivity with the team and patient satisfaction scores. They were through the roof. I'm curious, what were the keys to your success back then? And now how did that inform your leadership style over time? And then just a part two to that question, have you found any differences now that you're leading teams of designers and developers, engineers, digital folk? Is there any differences?
Yeah, a great question, Al. So yeah, I'm very proud of the fact of how productive me and my team were when I ran the division. And why am I proud of that? Is it for productivity's sake? Is it the money it brought in? No, right? What does that mean? That meant that we were accessible. The productivity meant that patients were able to get in. And I'm so proud of, having a clinic of pediatric, if you have kids, anybody's listening, try to go see a pediatric gastroenterologist right now, wherever you are. It is not easy, okay? So typical wait times in some big cities still, is like 3-4 months to go see a pediatric GI. There's a reason why everybody starts pinging me and like, can you get me in, right? And we saw everybody within, if you're an established patient, it was like within a day, we're going to find a spot, get you in, we're going to double book, we're going to triple book, we're going to make it happen because if you need us, and that was the culture. But you got to balance the burnout aspect of that, which we did. And I could go into that another topic because I know it's not a clinical, how to run a clinical program talk. But, but all that being said, and a new patient within 2 weeks was our standard. And we tried to get it, even within that. So it was to create access to help you when you're going through something, your kid has Crohn's disease and bleeding. You don't want to wait 3 months to be seen, right? I mean, obviously. So that was such an important part of it. But anyway, so I just want to say that's why I'm proud of the productivity, not for productivity's sake. But leading physicians and getting everybody, I think that it is the same kind of concept. So the answer to your question, this last part of your question, was no difference. And let me expand upon that, which is like, is it different to lead other type of people, not physicians? There's that term of missionaries, not mercenaries. Right, I think it's used in agile methodologies or what have you. But in healthcare, we're missionaries, not mercenaries. I hope that you're in healthcare because you're a missionary, not mercenary. And especially on the provider side, right? One thing you mentioned in my bio was I'm an Allegheny Health Network. You didn't mention Highmark, which is okay. But we're owned by a payer, right? We're owned by Highmark. And so just to be fair and make sure everybody listeners know, Highmark is a huge payer, 4th largest Blue Cross Blue Shield in the country, 7 million-ish members that owns a provider system called Allegheny Health Network in the Western Pennsylvania region. And the reason why that's so important, right, is that, everything I'm doing here and the reason why I'm here for a lot of other reasons is then to also, one, innovate the payment structure and what we actually focus on and getting out of fee for service. And the second reason is scaling, right? So we call ourselves at AHN the pace setter for scaling at Highmark. And so it's not just, I'm not trying, I want to solve for Western Pennsylvania. I want to solve for Pittsburgh region, but I also want to, selfishly, not selfishly, but I just really do want to transform healthcare as a whole. And I want this, Highmark has scale that AHN doesn't necessarily have. So I think that's another important part. But the point of all that is, man, I was just having this talk with one of our COOs, is that, I don't know, I'm telling you, like, getting a mom with a new diagnosis of Crohn's disease or a kid that needs a liver transplant and having that discussion with them and or a cancer kid that may not be here in the next year, going through that, one of all, like, I have grit. Like, it doesn't faze me with the politics of anything I gotta do, because if I gotta have that conversation, I can have tough conversations on operations or politics or whatever stakeholder it is. Okay, that's one. Two is, right, you're talking about getting stakeholders aligned and getting them on board. What is, like, clinical care? You got somebody coming in that thinks they have X, but they really have Y. They don't want to have Y. They rather have X. And you're trying to get them to, like, come on board to even just that realization and acceptance. and then treatments that are like chemotherapy agents, and they're, and the concerns and worries, and I don't want to do that, but hey, the outcome is better than the pain that you're going to go through. What is that? That's all change management. Now we do with, hey, you got to give up this to get that. So many things that I, as a doctor, did with my patients. Every time I have a tough situation now, what I do, that knowledge and what I did for so many years, 14 years of 100% clinical practice, I bring that to the table every day, Alan, and I use those tools and techniques that I learned to get those really tough patients to accept things. And so getting people to kind of come along. So that's from those difficult stakeholders. And as far as the teams go, I don't think in healthcare, especially in technology, we really talk about the mission enough, and really tell our story enough about how impactful this work really is on society and all of our patients and members and et cetera, and as well as providers go. And so we just talk about that a lot. We connect dots a lot, and making sure that sometimes these people in basements of just working on computers are at home now, a lot of them, not connected. They don't get to see the impact of their work. And so we actively spend a lot of time in our leadership circle, making sure that we have, glass box demos and whatever it may be, demo days, right? To really, close that loop so they understand. And that's the same stuff that we did with clinical care with our teams, right? Those nurses, those doctors, whatever it was, to be able to see, hey, I'm working my butt off, but and you get to see as a doctor, it's actually cleaner, right? Because as a nurse or a doctor, you get to see the outcomes usually, and then you're like, oh man, that, right? Because I mean, in my office right now, all my stuff is just stuff that patients gave me as like Dr. Barad, right? And I'm very proud of. That's what I'm most proud of. That's just sitting in my desk. And so you get to have that feedback loop, man, that drives me every single day. And when I left, Texas to be gone white, a lot of tears, right? And I remember one patient in particular was a short gut patient that almost went to short gut transplant. So very, very sick for a long time, central lines everywhere, grew up with lines, grew up in the hospital, line infections, right? And I got him off, not I, but like we as a team and everybody over time, we got him off all that stuff. And thriving, growing high school kid now, about to start driving. And I saw him since he was like 4 years old, right? And I mean, he cried, right? This kid, and I cried. And, his mom's like, and they're Spanish speaking. And if anybody grew up in a Spanish household, you understand the term mijo. But, she's like, mijo, he's going to help more people in the job that he's going to do, and because, so I say that all just because my clinical care really matters. I bring that with me because that's why I'm here. I'm here because I want to make an impact at a broader level. So
I love that. I had this conversation with someone here at Seamless the other day, and we were talking about how like both us and like providers sometimes get so frustrated with all the barriers and bureaucracy in healthcare. But then we talked a lot about the mission and remind us that, hey, what, like as frustrating as healthcare can be, it's such an impactful opportunity. Like the fact that no matter how bad it is, you get to go home and say, like we helped these patients today. That's an incredible feeling. There's no other like, industry where you can go home and say that. And it's so meaningful. So I love that.
Well, I tell you that, Josh, I tell you that story, but I mean but then I also call my nurses hostage negotiators. Because because like that's a great story. And then you're like, but then after that, they're like 10 moms yelling, screaming, cursing at them. It's hard. It's hard work, right? And you got to remember that one story, right? Of like why I do this when you're going through the tough times. So same thing to your point is like, yeah, some days are really rough. Some days are really hard. And you got to remember that mission. Yeah. Great
100%.
point.
Love to talk a bit about consumerism. So, Al and I have talked to a lot of chief digital officers who, as you mentioned, come from maybe the consumer industry and not from healthcare, and a lot of them use the word consumer. But I think you're one of the few clinical and digital leaders who are kind of gravitating more towards the term consumer over patient lately. Can you unpack that perspective for us?
Yeah, sure. I mean, this one's like, for me, Josh, I don't even know. It's like a no-brainer for me, I guess. I think that, and I don't care what term anybody uses, if it's consumer or not, but it's not patient to me anymore. But let me unpack that because I don't want anybody to get offended that they're not like, and patients, a doctor-patient is a sacred relationship, and I 100% believe in that. But what I mean by that is that you understand the connotation of patient is sick. And to some degree, the connotation of patient is established. And there's already an established relationship. There's already, some level of trust built, loyalty, stickiness, whatever you want to call it. But, a patient is someone that's already in the system, and you're in a reactive approach to that person. They've come in for a complaint or an issue, and you're reacting to that complaint or issue. And I think the consumerism for me is moving upstream. At the end of the day, it's moving upstream and being with you well ahead of you, ever being in our health system. And I love to get to a point where you never engage with our health system because, right, that's the whole point of wellness. And, we keep you well. You don't need to engage with the healthcare system. And I help guide you and navigate you and orchestrate your health, I won't even say care, in a fashion to keep you well, and look, as doctors, that's always like our running joke, right? Like doctors are always trying to put themselves out of business. Why? Because you're actually trying, right? You're solving, like you're not trying to keep that patient sick. You're actually treating that patient to not be sick. So it's part of our DNA. Most docs we talk to them, and I won't say all, but most docs we talk to them, they love to keep people out of their offices and keep them well. I get livelihoods and payment and all that and making sure incentives are aligned. That does need to happen. But from the consumerism standpoint, I know we've gotten decently there when me and all my executive leaders around me that are physicians or non-physicians don't get 1,000 calls a day about who should my mom or who should I see for XYZ thing that they need. Cardiologist, neurologist, who's the best at atrial fibrillation, Ashish? Who'll get me in? Can you make some phone calls? And I'm not like being disparaging to anybody that does that. I get it. I do. I just emailed the head of psychiatry for some therapy recommendations for a family member of who's good at this, right? I do it. We all do it. And I use that term democratizing healthcare. That's not democratization of healthcare, right? That's VIP healthcare. We talk a lot about equity and we talk a big game there. The action part of that is that information and that privilege of being able to get access shouldn't be something that should be living for those that are high income and have, those access points. That really should be something that when we get to consumerism, true consumerism, you should be able to shop, right? You should be able to shop. And part of shopping is making choices and having information and data to make intelligent decisions, knowing who is really good at XYZ and being able to gain access to see that person.
Maybe touching base on what you said earlier about, the fact that you're part of a payvider with Highmark and Allegheny, you're in this unique position where you can actually transform payment models in a positive direction to more, you mentioned more value-based care. And I think one of the challenges that we've seen lately is that a lot of the digital tools being used, like even just like telemedicine, virtual visits, it's primarily, fee for service. And then you may end up using it more than you need to sometimes or less than you should, depending on the situation. I'm curious, anything that we should be keeping an eye on in the market for maybe new value-based care models or approaches that you think will actually get more adoption of digital in a way that's actually useful? Any thoughts on that?
It's a great question, Josh. And I think obviously that's a probably separate podcast to talk about payment models in healthcare, probably like 10. But the short answer to that, and honestly, one of the major reasons why I'm here is that Highmark decided to their strategy is something called living health. It's okay, we don't have to go into the whole thing, and I'm not here to just, talk about one thing, but very simply, it's, there's a whole data aspect of that. There's care delivery aspect of that. There's a lot of other aspects of that I want to get into. But at the end of the day, living health as part of Highmark as a payer is saying, you know what? We're going to reduce total cost of care by improving outcomes. Josh, that's huge, right? Because I think even at, JPM, there was a panel yesterday, I'm not there, but it was like, hey, value-based care is not really going to be reality until we could actually have payers focus on outcomes, not just by denying care. It's, right? There's a lever that insurance, the payers have had forever that worked, to make money. And that was like, right, deny care, like no MRI, no surgery. And so, right, and it works. It works, and they could dial that up and dial that down, as they need it, right? Depending on what they need to hit. And I'm completely oversimplifying, and I'm not trying to make payers evil, and I'm not like anti-payer. I'm just saying that we know utilization management has been a big aspect. And I'm not saying it's ever going to, I hope it goes away at one point, but it's still here with us. But to say for a payer to really just say, you know what, we're going to go different. The future of healthcare and that MO isn't going to be the future MO. It's not sustainable to stay that way. We really do to improve the outcomes of our population. And we're going to focus on that as the main lever of total cost of care. That's why I'm here. And so that payvider aspect, I've talked to many leaders in this space. No one else is doing like we're doing it. And I'm not trying to like blow smoke up our, like, oh my gosh, we're the best and amazing. No, we haven't done it yet. So like, we gotta I don't know, is it going to succeed or not? But man, I want to be here to be a part of it and see it succeed. And that is, a lot of payviders, and again, it's different ways to do it, but a lot of the payviders that you see, either one, it's a closed system, right? And so, okay, that's great. Or it's a market that there's not a lot of competition. We got a big system in Pittsburgh that's not called Allegheny Health Network, right? That has a pretty decent market share, is well known around the world. We got competition, and we're open. 50% of our claims are through Highmark. The other 50% are everybody else. And or they're just buying a bunch of primary care practices, right? And trying to influence them that way. That's not the same thing as a truly, we're leading into what we call blended. Mm-hmm. And I mean blended, like truly blended, like one org. It's a really neat experiment. I'm so glad I'm here and learning, for me, just personally, right? I'm like, I didn't speak payer, not real payer, right? Just doctor payer, right? Oh, those payers those insurers up there, right? And so just again, we talked about empathy, they're not bad people up there, right? And there's like this kind of like here I'm in Pittsburgh, so I'll use the Steelers versus Browns, example. And it's always been that kind of mentality of my tribe, my team, and I shouldn't like that. So, we're really trying to build trust between the two entities. And that's another key word.
I respect what you're doing so much with, Highmark and Allegheny and the whole payvider thing. And it makes me think about, we're seeing a lot of these big tech like Amazon or pharmacy giants like CVS like start to come in and buy care delivery groups and get more involved there. But I think what we're also seeing is that a lot of them are focusing on I want to say almost like simpler aspects of care delivery, like, outpatient care and they're not having to deal with complex like inpatient situations and very high risk and complex patients sometimes, whereas in your shoes you're dealing with all of that, right? Like you don't get the choice of just the high margin outpatient stuff. You're dealing with like low margin complex situations with the goal of improving care for everyone. So I really admire that. I'm curious, like any thoughts on how maybe digital leaders of health systems should be reacting to this new landscape where big tech or pharmacy giants are coming into care delivery? How should folks compete, react? Any thoughts there?
Yeah, sure. Appreciate the question. Thank you, Josh. As I looked at career paths, right, as I really found passion in this space and believe in it, and I 100% believe in it, right? Obviously, just like you and others had opportunities or thoughts about where should I go. And man, I couldn't not be in a space where, you have to solve for Medicaid as much as you have to solve for Medicare Advantage, as much as you need to solve for women's health, as much as you need to solve, like, the scale and the fact of being able to touch all lives was something that really spoke to me. And I think it would be really hard for me personally to be in a company that, again, that's not to minimize those companies and what they're doing, by the way, but to be one company that says, hey, I'm going to take on Medicare Advantage for, I don't know, for this segment and this consumer and only this market. So I appreciate that. Now, if I ever do that, like 10 years from now, you can call me out and say, hey, you said you might, but things change, right? So who knows? So all that being said, I guess the question of just how do we lean into it? I'm going to be more simplistic with this answer because it's loaded too, as all things are, is that, and people have said this, but it resonates, is partnership is the future. Right. If we work with you, we work with any other company, it would be very, very clear this is not going to be a point solution that we're going to pay for. You're not a vendor. You're a partner. And if you're not a partner, we don't want to work together. I'm not looking for purchasing a software and saying, cool, we got it, add it on, to everything else we're doing. If you look at, we announced in our partnership with Google quite a couple years ago, part of that, and was announced at Health recently, was League, and creating that digital front door aspect of it from a payer perspective called My Highmark. And so, I mean, League, I'll just, shout out to them and give an example, is that's a partnership, because they to this level of robustness to build out a platform, a digital front door, not just a front door of an app, but a true platform play, has not been done. There's talks and discussions and meetings with them and brainstorming and whiteboarding constantly, right? It's a true partnership. And there's other vendors that, people can look up that are out there that we work with, but every one of them, the CEO of that company's out here and like sitting down and we're talking about, what if this, what if that, how can we build it together? And like a year after the partnership was inked, it's not just that, hey, the contract signed and like, oh, it's renewal, we'll come back in, right? Like that's not the relationship we have with most of our companies that we work with. So anyway, to your question is, the big tech, they partner and they compete and, at all the same time. And it's a very complex matrix world. And that's where I think healthcare is going. It's not going to be so simplistic. And then I get to somebody's like, oh my God, Amazon's taking us. Well, yeah, sure. They'll do this and then we'll partner with them on that. It's just, right. We just need to expand our mind, because that's, as doctors in healthcare, it's always been like, oh no, Tenet's coming in or ACA's coming, whatever it is. I mean, the other hospital down the block, and it's very easy to be like us, them. We don't partner. Why would you partner? You try to do the same services, right? We're not used to it necessarily in healthcare to be like, wait, we compete with this segment or this market. We partner on something else. So getting people to kind of just get their head around that healthcare, even though that might be super simple and, 10 years ago, or big tech is something new in healthcare. So, no, I look at all those. What it does though, and I think Alan, you mentioned, you didn't say the term, but you alluded to, which is burning platform, right? Is what I love when those things hit the news and people start publishing left and right. It makes my job so much easier. Right? Because it's just like, hey, Amazon's coming in. We got to go. Like, we got to offer something, blah, 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 right? I'm not really worried about Amazon per se, but, it sure helps me create a burning platform. I'm not saying there isn't one, by the way. Not saying there isn't one. 100% believe there is one. But it ramps up the heat.
It kind of reminds, so just a great point about like you can be partners in some markets and maybe healthy competitors in other markets. Kind of reminds me how like Amazon with Prime Video competes with Netflix. Netflix, I'm pretty sure, is still being hosted on AWS.
That's right.
And so when Netflix makes money, AWS is making money.
That's it. And that's it. And that's what I'm like. I mean, I'm always just, where's the win-win-wins? Right? Where does the payer win? Where does the provider win? Where does the consumer, / member / patient win? Right? I'm sure there's more wins than that, but that's at least it has to click those three.
In many ways too, it's kind of like if you stay consumer focused and don't spend too much time like watching the competition, copying them, you'll probably end up in a better direction anyways.
Yeah, and but it is neat. I mean, I gotta give these credit to these companies. Like, Maven. I look at Maven, for example, because it's just top of mind. I'm meeting with my women's health chair about like menopause and what are we doing around that from so like brilliant companies, brilliant things that they've done. I appreciate them because they spur my mind to be like, oh man, we should be thinking about that and what we're doing there, right? So like a lot of it's inspirational for me too. Not to say I can't work with them directly too, but we do have a program around menopause, let's say, or other programs around autoimmunity and what have you. And I think a lot of these companies sometimes will also appreciate just saying, hey, conceptually getting their hand. And it helps me also like go to those chairs that may not have thought about that, may think that that's not possible. I say, well, there's a whole company, that's been doing this at scale, well, with good outcomes. Are you sure it's not possible? So yeah, I get a lot of benefit out of it.
It's such a great way to spark a discussion is just, look what's out there. That's so awesome. Last question that I have is, today there is an explosion of patient-facing innovations, everything from remote patient monitoring to chatbots to digital care journeys. I'm curious, if you had to pick one, what are you most excited about today?
Man, yeah, I got a problem with that one because I'm such a boil the ocean person. It's hard, like focus, right? You're like, you sound like my dad, or you sound like Nick Reddy would always be like, Ashish, draw your box, man, draw your box. Like, and I always struggle with that. Gosh, what am I excited about? You know, it's not going to be a great answer because it's like the obvious answer, and it's data. It's data interoperability. That's it. The future is data in healthcare, but it's not just obviously data for data's sake, but the interoperability play there. Like, we are so immature, right? There's a lot of reasons. There's a lot of people that don't want interoperability that are very powerful, but it's going to happen. It's going to happen. And we have to, people need it to happen. It's the right thing to do. So I'm most excited about data interoperability. I'm not the smartest at that role, by the way, in any way, but I'm just most excited about it.
Yeah. It's not the sexy answer, but it's the necessary one. I think that's, and actually, I guess some people would find that the sexy answer.
Yeah,
Kind of
Richard Clark, my chief analytics officer at Highmark, would probably be like,
Yeah.
yeah,
Exactly.
yeah.
No, that's great. And so she's just being mindful of your time. Let's flip over to what we call the Fast Five lightning round. So again, 5 questions to get to know you better. First question we have: what is your favorite book or book you've gifted the most?
Yeah, I got it, man. I got it. I have it ready because it's sitting here, and this is my wife got this for me for my birthday. It's the Count of Monte Cristo.
Oh yeah.
And it's like one of the original, like, it's not first edition, but it's early edition. So I mean, it even smells good, right? So, so that is my book. I think one of the things that in life I've always tried to instill in my kids, because I don't know, a lot of stories behind it, but it's grit, right? Like I think that's, if you said what's the one trait that you just find to be most important, it'd be grit. And that book is such a great example of, I don't know what I would do in his situation, but I would hope that, I mean, not that I would, all the revenge was pretty weird. Okay, I'm not trying to kill people, poison, okay, but man, the grit, the persistence. I mean, he went through it, and so I think the journey that he went through, it's easy to do a podcast and talk about all the wins and all the great things, but we all went through really rough periods. And so just to talk about the reality of what he went through with that, just, I don't know, it resonates.
Yeah, that's awesome. Question 2: who is a person, either dead or alive, you'd love to meet?
Yeah, no, and so appreciate that. Man, it's such a weak answer because, like, I don't know. I'll give you like a silly answer to it, not even a silly, but like an answer to it. And maybe this sounds like pompous, and I'm sorry if it does to everybody on the podcast listening, but man, everybody has story. I love stories. I mean, if I go to a restaurant, if I go to a bar, if I go to, and I just talk to somebody, I'm just like, such amazing stories that people have gone through that you would never know. And I just like talking to people and just understanding, learning. Like, I don't have the celebrity crushes. I don't have like, oh my God, there's this one person that I'm like, really want to know. I don't want to meet my heroes. They're flawed. Okay. Like, we're really flawed as people sometimes. Right. So I don't have anything per se, but if I had to say, and somebody that I really admire is Teddy Roosevelt. And, that's probably who I've deep dived the most as far as, just his life was fascinating. I'd probably say him.
Very cool. Question 3: would you rather have super strength, super speed, or the ability to read people's minds?
Oh man. So that's a tough one. You're speaking to the first grade running champion. So I think that that was checked off, man. Super speed. So
did you race them recently, or did you win?
Yeah, I like the basketball. Will Ferrell won the ball. That's me, man. Yeah. That's awesome. That's a great question. I should do that. I have a pre-K. She's 2 years from now. I'll go race her.
You get the ribbon.
I don't know, man. I'll go super strength just because yesterday my 5-year-old did the Louisa. She had all her stuffed animals from Encanto. So I'll do that.
That's great. Question 4: what is something in healthcare you believe that others might find insane?
Yeah, 2 things. I mean, there's a lot. The obvious answer is always like facts, probably. Like, we use facts for everything. I'm sure everybody gives that answer, so I'll do that one. So what I'll say is this: when I started at Baylor Scott and White, and I'm not like, oh, this is probably a bad story for Baylor. Like, Baylor, don't say that. But when I started my practice, I will like transport my colonoscopes in my trunk of my car. Like I'm going to this place, and I'm like, that's not cleanly. Like, like,
Oh, no.
we don't do that anymore. Nobody does that. But I'm like, what? I'm driving? Like,
That's called a mobile
goes
health.
up the anus,
Yeah.
right? You're like, dude, am I supposed to be driving this around in my trunk of my car?
Wow.
So I think that's insane. The second story I'll give you, and I was trying to find it, couldn't find it. And this is like health tech nerds, right? I think they do a fab. I love that. I love their channel. I'm on their Slack channel, and I learned so much from that. If you don't know about health tech nerds, great place. Kevin Ryan, does that. So shout out to them. But it was like a year and a half ago. One of their weekly, kind of things it was like a heart failure clinic, and they were looking at data, and they found that just this one, I don't think she was a nurse. She may have been a nurse, or she may have been just a medical assistant. Called everybody, developed a relationship, developed trust with those heart failure patients, and would follow up with them almost like daily for a month as a pilot. Okay, how are you, Mr. Thomas? What's going on? What do you need? Blah, blah, blah. And I think like he reduced the readmissions and improved outcomes like by 30%.
Wow.
Like more than any digital health vendor out there, more than anything technology could do. Because and just the point is, and I always tell all my team, everybody around me, is I'm scaling trust is what I'm trying to do with technology. I'm not using technology just for technology's sake or because I think it's going to replace anybody. But you can't scale synchronous care. You can't scale the one person or trust that you have with your care team. So how does technology build around that trust and scale that to be 24/7, always on? That's what we need to be. We need to be always on for our patients, our consumers, our people. But we can't do that with humans and individuals, especially what's happening with staffing shortages in the workplace. Burnout, right? So anyway, I thought that was profound. And I always think about that as to like, that's what's going to reduce the outcomes, is that trusted relationship and building those relationships, but how to use technology the right way to scale that.
We
I
just
love
clone
that.
a nurse, it sounds like, right?
Yeah, dang it.
Cloning.
Just clone.
Oh,
just
yeah,
clone a
cloning.
nurse.
Oh,
Yeah.
sure. Maybe that's the technology I'm most excited about,
Right.
Alan, and we're going to clone people. Yeah.
Oh, that's great. And another podcast, you said you want to build Netflix, not make the blockbuster lines faster.
That's right.
It's thinking about it from a different lens. How do we scale trust? I've never heard that before, but then it makes so much sense. I love that. The last question that we have is, if you could travel back in time to any event or moment, what would it be and why?
Yeah. So leadership nerd, obviously Teddy Roosevelt. I think it's something that I just really enjoy. So I would say that a leader that I really respect and I love to just be next to is, one that everybody knows, Abraham Lincoln. But I'll throw another book, my second favorite book, Team of Rivals. If you ever read it, and it just talks about, man, this guy, like, it didn't matter, and he brought all the people that were running against him as president. And he's like, oh, you're gonna be on my cabinet now, and you're like, you hate me, you love me, yeah, I mean, you're trying to, you would backstab me in a second, whatever it may be. And he, at the end of his time as president and throughout his time, they were his biggest advocates, and just I think as leaders, a lot of this is leadership. A lot of this is leading through what's happening in healthcare and getting people on board, and I think and of course, in the backdrop of the Civil War and slavery, all that happening in the backdrop of that, I think that'd be a fascinating time to learn from.
Fair.
That's awesome. By the way, I was surprised. I thought you'd say you want to travel back to your first EHR go live and relive it all.
I'm done with those days, man. I'm done with those days. No, listen, I still think there's a lot of, again, I want, we got to do better. We got to do better from that, Josh. So we got to do better with the EHR. Got to be in every other industry, right? Like, you don't look at technology and say, oh, it's a burden. Anything. You like, oh yeah, that automates this and that, like, improves my life, and that consumers, right? Going back to consumerism, like, you look at technology, like, oh my God, that solves 1,000 things that I used to. I had to do that manually. But doctors, many of them would be like, give me paper charts again. I'll go. That's crazy. It's crazy that you would say technology slows me down. that manual charting, you know it's not the right thing because nobody can read it and like the labs aren't shared and whatever. So I'm not saying anybody's trying to go back there, but doctors would tell you, right? If that we're living in the manual days. I saw 30% more patients when I had manual charts.
It's like me saying, hey, Ashish, I'm not going to text you anymore. I'm going to go back to writing letters to you.
I'm going to write you letters.
And mailing them.
And you'd be like, cool, that's faster than this.
Yeah.
Right? I mean, it's crazy. But that's what it is. You know, and so we got to do better. We got to just fundamentally, we got to take it back down. I want to burn it all down and just rebuild it the right way, you know, and be truly seen like what cell phones were when they first came out for doctors, removing pagers and phone booths. That's what technology should do, right? The iPhone obviated like 50 different things you didn't need anymore, from a calculator to a flashlight to a, you know, like stuff that you would be like, wait,
Camera.
not anymore because of an iPhone, right? So that's we got to get there.
Well, that's awesome. I think it's a great note to end on. It kind of summarizes your optimism for the future of the right technology in healthcare and how it can really lead to this paradigm shift of how we're using technology in a way that's actually helpful and not to the detriment of our time and effort. So thank you so much for coming on the show today, Ashish. For folks listening, you can find Ashish on Twitter. I believe it's at #2#. That's the number 2 in the middle. And that's a wrap for this episode of The Digital Patient, hosted by Seamless MD. You can follow us on Twitter at Seamless MD. And if you like the podcast and you want to learn more, you can visit www.seamless.md. Ashish, again, thank you so much for spending your time with us today.
Thank you so much for having me, guys.